Hello, I'm Dr. Nathan Zasler, and I'm here to speak to you on the topic of traumatic brain injury and what vocational specialists need to know. I'm very excited to be here and have the opportunity to present this information to you and hope that it is helpful. Traumatic brain injury is an epidemic condition in the United States of America. We see all kinds of brain injuries from mild to severe. The ones that probably get the most attention are those that are the most severe and result in not only catastrophic changes for the patient, but also significant others and family members. It is important to understand that traumatic brain injury is a condition that affects about 1.7 million persons in the United States on an annual basis. That's looking at all severities of injury. It is one of the contributing factors in about a third of all injury-related deaths in this country. And lastly, it is important to note, particularly with regard to milder forms of traumatic brain injury, that the true incidence is unknown, as many individuals with milder forms of brain injury don't seek care in centers that keep track of injury-related statistics like they do in major hospital centers for moderate to severe traumatic brain injury. Additionally, one of the challenges in looking at the research on brain injury is the fact that there's no accepted definition for traumatic brain injury that's used across all care providers. This is particularly true for the milder forms of injury, what are referred to as MTBI, or mild traumatic brain injury, also known as concussion. One needs to understand when looking at the topic of traumatic brain injury that typically it's young males between the ages of 15 and 24 who get injured. And there are all kinds of reasons for that, which we won't get into today. But the major reason probably is greater risk-taking behaviors associated with that age group among males compared to females. Most persons are injured in motor vehicle accidents, although assaults, falls are also other common causes. And there are differences in terms of age group, with the other major age groups being very young individuals and older individuals as far as higher prevalence of TBI. Additionally, it's important to realize that many of the individuals who have these kinds of injuries also have concurrent physical injuries that need to be considered in their overall clinical presentation, and those may be relevant for factors to consider in the context of vocational reentry and rehabilitation. Approximately 80% or so of individuals who sustain injuries sustain the milder forms of injury, with about 10% for moderate and 10% for severe as far as overall relative incidence. It's also important to understand that patients can have differences in terms of classification factors, so sometimes it's confusing as to whether someone had a mild versus a moderate versus a severe injury, particularly in those gray zone areas where a patient may have some parameters that make them fall into the mild group and some that may, for example, fall in the moderate category, and we'll talk a little bit about that. So what are the things that we look at to define severity of injury? Certainly imaging is one of those factors. As I have up on the slide here, this is an image of a more severe brain injury where you see significant frontal lobe involvement. That would be towards the top of the screen, the wider areas. We use imaging as one parameter to look at severity, although clearly it doesn't correlate in any absolute terms, certainly, with function. So you can see patients who have very abnormal brain scans who are highly functional, and people who have relatively normal brain scans who have significant impairment and associated handicap. The Glasgow Coma scale is maybe the most historically well-known parameter that's looked at to gauge injury severity, particularly acutely. It's generally not used in the post-acute arena. GCS score, as it's referred to as an acronym, looks at three parameters that are scored in a not equally weighted manner. You have a score range of 3 to 15, with 3 being the lowest, 15 being the highest. Typically, mild traumatic brain injury would be defined as scores between 13 to 15, moderate TBI as scores between 9 and 12, and severe TBI scores between 3 and 8. Since mild traumatic brain injury is the most common form of brain injury, I wanted to spend just a couple of minutes on that particular severity of TBI and talk to you a little bit about the more commonly used definitional criteria for that condition, although certainly there's controversy even here. The American Congress of Rehab Medicine, for those who are more rehabilitation oriented, came out with a definition of mild TBI, and they defined it as a traumatically induced disruption of cerebral function as manifested by at least one of the following criteria: a loss of consciousness of no longer than 20 minutes, any loss of memory with regard to either what's termed retrograde amnesia, meaning memory loss before the insult, or anterograde amnesia, which is memory loss following the brain insult, any alteration in mental status at the time of the accident, even in the absence of loss of consciousness or amnesia. So again, just as a clarification point, you don't need to have a loss of consciousness by this criteria to have sustained a traumatic brain injury of a mild nature. Physical symptoms which are potentially brain-related, again, that's a bit of a wishy-washy criteria because it leaves open the potential for false positive diagnoses, that is, saying someone's brain injured when they're not, and development of post-traumatic cognitive deficits which cannot be explained all by emotional factors. Again, another difficult point for truly ruling out other causes, and one where there's certainly some debate and argument about how good a criteria it is. We also have some additional qualifiers for this definition for mild TBI. GCS has to be between 13 and 15. It can't decline. That is, occasionally a patient will come in with what looks like a mild GCS and then have a decline in their GCS score. That person would no longer be considered as having had a mild TBI. Post-traumatic amnesia has to be less than 24 hours. These criteria are what are termed empirically based, so there's no good research to say it's 24, 22, 26, but by consensus it was set at 24 hours or less. Anything above that, by criteria, empirical, albeit they may be, you would no longer be considered as having had a mild TBI. And loss of consciousness no longer than 30 minutes, although if you compare different definitions internationally that are out there, some will use 20 minutes, some will use 30 minutes. Some problems with the definition are the rate of false positive diagnoses, and lumping of patients may undervalue predicted impairment. That is, there's some literature to suggest that patients who have, for example, abnormal brain imaging, who have a GCS of 15, don't do the same as far as their cognitive behavioral outcomes as patients who have clean CTs, that is, no obvious abnormalities, acutely, who have GCS scores of 15 as well. So important to keep that in mind. The next thing we're going to talk about briefly is pathophysiology of injury. Direct impact of cranium is not necessary for traumatic brain injury. You can have brain injury due to forces acting upon the neck and head that create strain forces on brain tissue. Loss of consciousness, as I've already said, also not a necessary factor for incurring a TBI. The hallmark of so-called diffuse axonal injury, which is now more appropriately termed traumatic axonal injury, or TAI, is, as I mentioned, the strain forces, and that occurs due to deceleration, acceleration of the head, not necessarily, not necessarily with impact injury. You can also see it with stretching of the cervical spine, as in cervical whiplash type injuries, and skull distortion due to pressure gradients being created, as with blast injury, as an example. So this is a diagrammatic picture of what happens with strain forces. This is the normal brain. This is what occurs with axonal damage, which typically occurs at the gray-white junction between the areas of gray matter and white matter in the brain that are more susceptible to strain and shearing forces. Types of brain injury that we want to discuss, just so you have a general understanding of them. The two primary types are for lack of better terms, primary and secondary. We also talk about tertiary brain injury and even quaternary, but we won't get into that today just to keep this conversation more directed at issues that are going to be pertinent for you all as voc rehab people. Primary types of brain injury include local contusional or bruising injury to the brain and diffuse axonal injury or traumatic axonal injury, as I previously discussed. The other issue that needs to be kept in mind is what happens after that immediate injury in terms of what we term secondary brain injury, and that includes issues like lack of oxygen to the brain, blood pressure dropping out, and not getting sufficient blood flow to the brain. Those things are referred to as hypoxic and ischemic types of brain injury. Changes in the pH of the fluid in the brain can also result in additional secondary brain injury related mainly to a condition called acidosis. And also you have a release of neurochemicals in the brain referred to as a neurotoxic cascade that can also result in additional so-called secondary brain injury. Tertiary types of injury or impairment that can result after more severe injury include things like later development of neurological disorders such as epilepsy or movement disorders, things like contractures, among others. So some of the acute neuromedical issues that you should know about, although by the time you see patients they probably are not going to be as pertinent, but looking at records and understanding historical factors associated with a case that you're working on, understanding the parameters associated with acute severity determination like the GCS is important. The imaging findings, as I discussed earlier, understanding the acute range of neurological presentations that can occur with a given severity group. So what do you expect after mild versus what do you expect after a moderate versus a severe is important, and it is a spectrum disorder. So those presentations will vary widely across severities of brain injury. Look for other injuries that may be masquerading, if you will, as post-brain injury impairments when in fact they may not have anything to do with a brain injury per se, but rather with associated injuries, peripheral nerve injuries, cranial injuries, or what we term cranial adnexal injuries. So you can have visual impairments because you injured something in your eye from trauma, or you injured something in your inner ear that could cause dizziness without necessarily endorsing a brain injury as the explanation. Atypical symptoms need to be looked at carefully by sophisticated clinicians. They can be just uncommon, real neurological problems, or they could be something else, such as psychogenic problems related to more a psychological response to the injury as opposed to an actual neurological injury from the brain damage. Transient phenomena. You can see problems early that don't stay around for very long, that could be real and neurologically based. It's important for the treating clinicians, maybe not so much the voc people, to have looked at those issues, review EMS records, emergency medical services records, ER records, among other things to look at. And then understanding for everybody, I think this is true, the expected scope of problems that are going to be relevant to that given patient population. So for example, seizures typically aren't an issue after mild brain injury, whereas after more severe penetrating brain injury, you can see the incidence over 30%. Acute record review is also important, germane to the issue of understanding what the initial neurological presentation and exam looked like, as well as the history as available to the clinicians. Was a loss of consciousness reported versus actually observed? Or was there no loss of consciousness and maybe just an alteration in consciousness, such as dazing or confusion? The initial GCS should be documented pre-resuscitation as well as post-resuscitation. The post-resuscitation GCS has more value as a prognostic indicator for long-term outcome than the pre-resuscitation GCS. What were the X-ray results, the diagnostics, head CT, MRI if they were done, among other tests. Neurodiagnostics in general, depending what's been done, important to understand those tests for the clinician in terms of providing you as the evoked person with more than less information. That includes tests like evoked potentials, electroencephalograms, which are referred to as EEGs. Those look at the brain waves, are used mainly for assessment of epilepsy, but not only for that. Also important to understand whether somebody presented at the time of their injury with positive evidence of having used illicit substances. If they were inebriated at the time of the incident, that may artificially lower their GCS score and make them look more neurologically injured than they actually are. So those are all kinds of things to be aware of in the context of reviewing acute records, as is the fact of looking at risk factors for hypoxic ischemic brain injury. That is, did they come in with a very low oxygen saturation when that was checked? If you did a blood gas and their oxygen came back below 70, that would be significant. Or if they dropped their pressure and didn't perfuse their brain adequately, that would be a significant risk factor for ischemic injury. When we work with individuals post-traumatic brain injury, it's important to understand not just the injury and how they are after the injury, but who that person was that came to the injury and something about their history on multiple levels. So those kinds of things that we look at include issues like prior traumatic brain injuries, which would be significant if you had another one. Prior motor vehicle accidents, falls, assaults. It's rare to be in significant incidents like that and not have sustained some sort of brain injury, concussive or otherwise. So sometimes people don't necessarily connect, have you ever had a traumatic brain injury, with those kinds of incidents, so it's important to ask. And it should include also things like, did you play competitive contact sports in school, and ask about that history if the answer was affirmative. So people who play football, you ask things like, did you ever get your bell rung? And they go, oh yeah, I did multiple times. Those are forms of concussion, getting your bell rung as an example. Prior psychiatric or psychological history would be pertinent to know, prior learning disability or attention deficit disorder, all things that would be important to know in the context of attribution of current symptoms and impairments to a particular injury versus to something pre-existing. Other medical conditions which can mask or make people look more impaired, for example, hypothyroidism, can cause cognitive impairment, and you'd want to know if somebody was hypothyroid and then nobody restarted their medicine after their severe brain injury, as one example. And then what's their history of substance abuse in terms of alcohol, illicit substances, among other drugs that might be in their past. Acute record flags as far as red flags and relative to long-term prognosis and impairment issues would include things like skull fractures, intracranial pathology, things like bleeds within the ventricles, which puts someone at risk for things like hydrocephalus. Significant duration of PTA has also been shown probably to be the most strongest predictor of long-term outcome. So if PTA is greater than 2 months, that's a very poor prognostic sign for functional independence of the individual. Positive drug and alcohol screens at time of acute injury, and risk factors, as I mentioned, for hypoxic ischemic brain injury. A word on whiplash injuries. From my personal experience over 25 plus years of doing this, these are often missed and often can explain a lot of the symptoms that patients report after brain injuries that occur concurrent with the brain injury. That is, they had a concussion but also had a cervical whiplash injury. So chronic pain issues being quite prevalent in this patient population, often taking the form of referred headaches. So the problem is in the neck, but the perception of the pain is more in the head, typically referred to the same side of the head. Cervicogenic dizziness, another common problem in whiplash patients that often gets over-attributed to central causes due to the brain injury. Myofascial dysfunction, that is changes associated with overstretch injury to the muscle and activation of what are called trigger points with pain and including what I referenced earlier, referred pain, not just pain where the problem is, but pain going to other sites as well. And then there's also been reports of types of migraine being generated after whiplash injury, particularly in younger women, what has epidemically been referred to as Bickerstaff's migraine, more commonly referred to now as basilar migraine. You can also see vascular or nerve injury like carotid dissections that may result in further brain damage if not caught early and treated. So again, a complex type of injury, often underappreciated by evaluating clinicians in my experience. We also now move to another type of injury that doesn't, again, necessarily imply that you had a brain injury, but can be seen concurrently with TBIs, mild to severe, and that is damage to the head or structures within the head. Again, important to separate these out from those impairments associated with brain injury. So you can have, on the basis of banging your head hard enough, whether that's due to a vehicular accident, a fall, an assault, or a simple thing like throwing yourself backwards on your bed and hitting the backboard with your head, you can have problems like dizziness, ringing in the ears that's referred to as tinnitus, smell and taste impairments, visual problems, and peripheral nerve injuries, as well as vascular trauma. From the standpoint of brain trauma, which is what we're here to really focus on, but I thought it was worthwhile mentioning those other conditions, important to understand the natural history of the condition and what kind of recovery is expected. So typically people with milder forms of injury generally do well and do not have long-term sequelae or problems for the vast majority of those patients. And if you look at the literature is relatively sparse on looking at patients beyond a year post-injury after concussion in terms of methodologically sound research. But from what the overall research shows, probably 5% or less have long-term neurologically based problems consequential to an otherwise mild form of brain injury. Whereas people with moderate to severe injuries, typically the rule of thumb is that those people are going to have long-term impairments, but there's often quite a range. So you can see people with even the most severe brain injuries return to independent living, returning to their prior job. That's not out of the question, just inherent in the fact that they had that type of injury, although it would be statistically more likely that they would not, but it's certainly possible that they would. Understanding pre-existing conditions, whether that's the types of problems I talked about before, to issues like what their pre-injury personality was. So if somebody was obsessive compulsive, they're going to have a more difficult time adjusting to even subtle changes in their functional capabilities following this type of injury than somebody who was a type B personality, as an example. Another factor with pre-existing conditions is looking at how personality typically changes. So typically what you see is an amplification of pre-injury personality traits. So if someone had a temper before, they're going to have more likely than not an amplification of those temper control problems post any significant traumatic brain injury. We also need to differentiate between issues of impairment and issues of disability. Impairment is what the clinician finds on exam, like weakness in the right arm. Disability is how it impacts that individual functionally. We also need to understand rare versus common neurological sequelae after acquired brain injury from the standpoint of the clinician, whether therapist or physician. From a VOC perspective, if you see things that you've not seen before, my recommendation is you talk with the treating doctor, clarify how you can best broach that problem in the workplace or in the work reentry process. And then understanding prognostication issues, there's now quite a bit of literature looking at what are the types of variables that most prognosticate better return to work rates versus poor return to work rates, and it's important for folks like yourselves to be familiar with that literature. The main impairment areas that we see in these types of patients that you need to be aware of include impairments in cognition, emotional control, behavior, physical impairments such as limb motor weakness, sensory deficits, which could be limb related, or they can be related to the traditional senses: vision, hearing, smell, taste, etc. Neuromedical issues such as epilepsy probably being the one that scares people the most. But again, when properly managed, my experience is most epileptic disorders are controllable with appropriate intervention, assuming the patient is compliant. And language and communication-based impairments, which often in the community are probably one of the more challenging things to deal with. So if people have things like dysphasia or difficulties understanding what you're telling them, or language impairments as far as expressing themselves, those can be quite challenging. The other area that I would just mention impairment-wise that I've found the most challenging in terms of work reentry are people who have very dense amnesias, so that they can't consolidate memory from hour to hour, day to day. Those are tough, challenging patients to work with. Cognitive dysfunction, again, important to understand that brain injury is one of many things that can cause cognitive impairment. Pain, if it's present, can certainly interfere when moderate to severe with cognitive processes, particularly attention and secondarily memory consolidation, because you're not able to attend as well to task. Affective disorders, significant anxiety and depression can impact cognition negatively, among other conditions that I've listed here, which we won't get into simply because of time, but you can look at those and read up on them. Behavioral dysfunction, very common after traumatic brain injury, more so after moderate to severe injury. You can see a range of problems, depression, anxiety-related disorders probably being the most common. For the record for this discussion, post-traumatic stress disorder, which has received a lot of attention mainly because of the military experience, would be considered in the or under the anxiety umbrella. As far as affective disorders, rarely or more rarely you can see conditions such as psychosis, bipolar disorder, result from a traumatic brain injury, although there's some debate about some of those conditions and their causal relationship to traumatic brain injury. It's also important to understand that oftentimes, particularly with depressive disorders, there's a delay to onset of those disorders, so they don't necessarily show up right away. Year 1 to 2 is probably highest risk for onset of depression, whereas anxiety disorders tend to be evidenced earlier after injury. Again, various other factors need to be considered here in the context of things that can perpetuate behavioral dysfunction, including lack of sleep or poor sleep that's non-restorative, that is, it's not physiologically restful. Problems with pain can also make patients more irritable, as an example, and be sort of a light under the fire, if you will, or adding fuel to the fire, making the condition worse. So those kinds of things need to be looked at as well. Examination of the patient with traumatic brain injury, important for the clinician to know what to expect, and similarly to know what not to expect. Be thorough in terms of how the clinician evaluates patients. I often find clinicians are rushed in today's world of managed care and don't take sufficient time to do good exams that look at both neurologic and orthopedic aspects of the examination, particularly after multi-trauma type injuries. It's important to include, for both myself and you all as VOC rehab people, adequate mental status testing so you have an understanding of that person's cognitive abilities and limitations, as well as appropriate psycho-emotional testing. So if somebody has a social phobia, that's clearly important to identify early and treat it so that you're not getting a patient who has inadequately or never been treated for a problem that may interfere with their vocational reentry. It's also important, particularly in cases where there are clear secondary gain issues, and I know people often don't like to talk about it, but the realities are there, things like work comp, Social Security, legal cases. There's a much higher incidence of what is termed response bias, that is, patients coloring their reports and their performance on tests of function. There are actually ways to objectively evaluate that in terms of tests for how well someone's reporting. If they're reporting down the middle being stoic and underreporting versus exaggerating. So that's important for clinicians to look at as well. Neurodiagnostics, just a few words on that for you. Clearly, neurodiagnostics are only as good as the test being done. It's ceiling and floor effects, as we refer to them, and the person interpreting the tests. Because a test is normal doesn't mean the patient's normal, and one needs to understand what the limitations of the test are, what the specificity and sensitivity of the test is, among other parameters. Neuropsychological testing, as one example, can show a pretty clean level of function, but then when you get that person out in the community, they don't do particularly well. That's particularly true with patients with frontal, executive-related impairments who may do better under the structured circumstances of the in-lab neuropsych test scenario, but break down when taken into community and not in a structured environment. So that is referred to as the ecological validity of a test. So it's important for people to understand those nuances in the context of looking at test data. And then there are also tests that can be overinterpreted depending on how a person giving the test wants to interpret them. And unfortunately, you can give the same test results to 3 different clinicians who are the same specialty and get 3 different interpretations. So again, important to make sure that your patients are being treated by people who understand brain injury, understand how to interpret tests and what tests are relevant versus not relevant. There's also in this field, as with many other fields, junk science issues that you need to be aware of in terms of how tests are used, what normative data is used, how much data there is for that test relative to its use in traumatic brain injury versus other disease entities. Just a few comments on neuropsychological testing. Obviously, when a clinician, whether it's me or someone else, sends someone for neuropsychological testing, it's important that we get good data and interpretation based on good data. Oftentimes there are controversies about what the cause of that person's cognitive issues are, so it goes to what's termed differential diagnosis. A good neuropsychologist will take into consideration issues of mood, such as we discussed, issues such as depression, anxiety, issues of pain, among maybe the 3 most important in terms of trying to differentiate what's related to brain injury versus what's not, but clearly there are other issues as well, which we won't get into today, but there's a long laundry list of differential diagnostics that needs to be considered. And then understanding what that individual's pre-injury baseline level of function was cognitively as well as psycho-emotionally. Did they have psycho-emotional or psychological vulnerabilities? So for example, did they ever go through any emotional abuse, sexual trauma? Those would all be significant historical factors to edify. And then issues of adequate attribution of emotional status and motivation, as I mentioned before, relative to issues of response bias and what is termed effort. And there are now actually tests that we can do to assess for individuals' level of effort in the context of test taking. And this gets us into issues of causality determination, which may not be as relevant for you all vocationally, because when you get a patient, you're basically told, this is what's wrong with them, A, B, C, D, and you sort of work off that list. But my words of wisdom to you are, if you have questions about that, please feel free to address those to people like myself, the treating clinicians. That's what we're here for, and it should be, in my opinion, a team process. But again, we get into issues of when symptoms started after an injury in the context of understanding if it's apportionable to an injury, corroborating those observations with other individuals, the consistency of the complaints with expectancies. So for example, if somebody's telling you they have triple vision after an injury, which I was told the other day by a patient, that's highly unlikely and more likely to be what we call non-organic or not real. So understanding what is a reasonable complaint versus one that may be fabricated is important. understanding the natural history of recovery in the context of what we do as rehabilitation clinicians is critical, and understanding what you can do to effectuate an improvement in that, whether it's greater expediency or better outcome in the long term, is also part and parcel of what fall under our responsibilities. When patients get worse, you need to know that that's something that's important to make a treating clinician aware of. So if you're seeing a patient coming in and presenting as more fatigued or more irritable or more spacey cognitively, I would tell you that your responsibility as a voc person is to let somebody know about that. Certainly if someone has a critical event like a seizure, that would be something you immediately call paramedics for and inform the treating clinician that that event occurred. Treatment issues, I think this may be more the crux of what's going to be of interest to this audience, but of the things that we can do as rehabilitationists, yourself included, to help people in general and as it relates to vocational reentry, modulating physical impairments. That includes looking at ways within the workplace that you're in as to how you can compensate for any physical impairments that that person has. So if a standing device enables them to stand at their job for longer periods of time, something like that might want to be considered. Facilitating sleep, making sure somebody's getting restorative sleep is one of the first things I look at when evaluating a patient. We want to make sure that that restorative sleep cycle persists on an ongoing basis. So if somebody complains to you about, I'm getting poor sleep, again, that would be something that you would want to let the treating clinician know about. Modulating pain. So if somebody tells you what they're doing in terms of your work activities with them is causing their back pain to go through the ceiling, and before that they were a 2 out of 10 and now they're an 8 out of 10, that's not what you want to see happening. Obviously that would be another red flag that you would want to inform the treating clinician on. But my job and the treating clinician's job who are involved with the rehabilitation of the patient is to try to find those pain generators, treat them, decrease the pain, make the patient more functional even if they have persistent pain. But we want to see that pain level come down. Modulating behavior, so whether it's irritability, aggression, emotional ability, crying at the drop of a hat, or anxiety or depression, whatever the form may be as far as the presentation, we want that to be modulated as much as possible to allow that individual to function more, for lack of a term, I don't love the term in quotes, normally in the workplace and interact with individuals in a more adaptive fashion, provide cognitive compensatory strategies. Now, when people talk about cognitive remediation, that can take many forms. It can take the form of sitting in front of a computer and doing attentional training, to treating somebody with cognitive enhancing medications, to teaching somebody cognitive compensatory strategies like using their iPhone, like many of us doctors use, to keep track of their schedule, have alarms for taking their medication, etc. So cognitive rehabilitation really doesn't mean one thing, it means a lot of different things. And there's lots of things that can be offered to patients in terms of improving their functional abilities when they present with cognitive deficits. Fatigue is a common problem that we see following traumatic brain injury. Again, there's lots of different causes. To say that the fatigue is caused by the brain injury is really an exclusionary diagnosis. That is, you rule out everything else, and then you can say it's due to the brain injury or neurogenic in etiology. Fatigue can be caused by pain. Fatigue can be caused by poor sleep. Those are two common causes. Fatigue can be caused by brain injury. Fatigue can be caused by anxiety and depression. In the general community, psychiatric disorders, that is depression and anxiety, are the two most common causes of fatigue, interestingly. And then obviously it's important for people who are trying to re-enter the workplace to assess their driving skills. We now have various methodologies in place to formally and objectively assess in a rehabilitation context people's driving skills, to look at how things like reaction time, attention span, divided attention, multitasking, all interface in the context of driving, which is probably one of the most complex functional activities that we do as humans, and also one of the most dangerous. So it's really important to clear people and evaluate people adequately before clearing them. Work skills, leisure activities for safety and clearance would also be among the areas addressed in the context of ongoing TBI rehabilitation. Therapy referrals, again, the points I want to make here are really more in overview fashion. In my experience, it's difficult to find therapists who really know brain injury well. They are certainly out there, but they're few and far between. So you don't just refer to any PT, OT, or speech-language pathologist. You want these patients, particularly those with more challenging problems, to be seen by therapists who have experience at treating this patient population. Physical therapists typically will focus more on motor control issues, spasticity management, myofascial pain management and treatment, vestibular treatment, and balance disorder treatment, whereas OTs tend to focus on cognitive retraining, as do speech-language pathologists, and activities of daily living. Speech-language pathologists deal with issues such as reading, writing, auditory processing difficulties, pragmatic language skills, so how people communicate in social contexts, among other things. Who should treat? At least as far as physicians, my opinion for years has been there's not one specialty that you think of when treating brain injury. Unlike if you have heart problems, you go to a cardiologist. When you talk about brain injury, long-term care, it really is a physician who understands TBI and understands what can be offered those patients to improve function. So it may end up being a physiatrist or PM&R, physical medicine and rehab physician, could be a neurologist, could be a neurosurgeon, could be a family practitioner. It depends where you're at and what the resources are. Finding someone who knows their stuff and has experience and a good reputation probably should be first and foremost on the list as far as making that decision. Ideally, an interdisciplinary, holistic, functionally oriented approach should be used in the context of neurorehabilitation following traumatic brain injury. When we look at rehabilitation programs associated with TBI neurorehab, appropriate and prompt medical diagnosis and treatment is paramount from the get-go. Reassurance of the individual and their family as that's able to be given. Again, when you have a catastrophic brain injury where you don't expect someone to live, it's a different story. But in the context of any other variation of outcome prediction, ideally early education and reassurance and support and maintaining hope and motivation, I think, are critical. Educating, as I mentioned, the individual when they're ready for that, and providing support to the individual and family are paramount, as is ongoing counseling services to address ongoing issues and challenges, regular monitoring by treating clinicians, and provision, as I mentioned earlier, of compensatory strategies. Treatment locations can vary across the continuum of care, and ideally communities should have a continuum of TBI care available from the get-go in the field to community-based services and long-term follow-through, including vocational services and respite care, among other long-term care services that might be available or should be available more specifically. Return to work issues. Most folks after mild to moderate TBI can return to some form of gainful employment based on the literature. Persons with severe TBI are more challenging, and you'll see variable return to work rates depending upon the services available in the community and the methodology used in the context of vocational reentry services. Severe physical limitations generally are not the major obstacle in work reentry or job maintenance based on both the experience and the literature. In conclusion, we need a better foundation for clinical diagnosis and treatment. We need a better understanding of risk factors for delayed and poor outcome, including poor vocational outcome. Need more sensitive and specific diagnostic measures for TBI, particularly mild TBI, where there are often controversies on how much of this is neurological versus how much of it is something else. Differential diagnosis remains paramount in clinical care for any of the kinds of problems that we see presenting in these patients. It is important to understand that from a clinical neurorehabilitation standpoint, there's a lot that can be done for these individuals to facilitate recovery and global function. For those interested in the topic, I'm giving a little plug here. The second edition of Brain Injury Medicine Principles in Practice will be available here shortly, and for those interested, we have the next World Congress of the International Brain Injury Association coming up in San Francisco, March 19th to the 23rd, 2014. We hope to see everybody there. If you're interested in communicating with me, my email is as follows. Happy to respond to questions. Can't make diagnoses over email, but can certainly lead you or point you in the right direction. If you're looking for literature or have general questions, I'm happy to be of help there. Thank you very much. It was a pleasure being here, and thank you for asking me to do the presentation.